Thank you for the kind introduction. It's a privilege to be here, and I'm thankful for the invitation. So I decided to change the title of the program of my speech because it was a bit boring. I think before was, and I was wondering if people understand what this is all about. But it's all linked, and I think we'll come together. Hopefully, with my presentation, which is about epilepsy, health, and disease. So because you can have epilepsy on its own, but it can come with other conditions that we need to know about. Let's start from the basics. What is epilepsy? And I don't know if it shows, actually I'm not sure if it shows here, but the practical definition according to the International League Against Epilepsy says that epilepsy is a disease of the brain, which is one of the basic stuff. And it helps us to localize where the problem starts in the first place. And it says that, you need to have at least 2 seizures 24 hours apart, or at least 1 unprovoked seizure and another risk factor. And then you have a diagnosis of an epilepsy syndrome, which basically is a combination of some kind of a seizure plus an EEG abnormality. And then they say at the bottom that the epilepsy is resolved when someone has been seizure-free for 10 years. So although it doesn't specify that it's a chronic condition, epilepsy is a chronic condition, because if you need to be seizure-free for 10 years before we say the epilepsy is now kind of resolved or hopefully gone, then it is a chronic condition. And we don't think of it like that all the time, which I think is important to have it in the back of our head. And the perception of epilepsy, of course, is seizures. I need to take my anti-seizure medications, and okay, what is causing it, and what test do I need to do, like an MRI brain or EEG, and this is where most doctors will start and stop, I think. But if you go back to what is described as a conceptual definition of epilepsy that was published in 2005, again by the International League Against Epilepsy, they say that, of course, a disorder of the brain characterized by the enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, psychological, and social consequences of the condition. So there is more to it, right? It doesn't come just the seizures and nothing else. So it's more to it. And of course, it's a chronic condition, and it can affect other parts of the body. For example, there is biological change, like hormonal changes that could be because of the dysfunction of the brain and the effect of the seizures. There is cognitive problems, usually poor memory, and psychological problems. People get stressed out, the anxiety, they can have low mood as a result of what is happening to them. And there's social issues. Of course, you cannot drive, you may lose your job. So there are a lot of other things in the package that is not just the seizures. And this is basically living, this thing is about living with epilepsy and otherwise being healthy, right? But all these problems affect you still. So again, you can have, as a result of a seizure, there can be injuries. People break their teeth, they have a fracture, they have a shoulder dislocation, burns very rarely, drowning or near drowning, I guess, because if you drown, you're dead. Hormonal changes, more women have polycystic ovarian syndrome. People complain sometimes of sexual dysfunction. Women may have menstrual irregularities or premature menopause. There is metabolic effects. For example, your cholesterol may go up, which is usually a medication effect, or you may have low vitamin D. And again, you're more prone to have osteopenia or osteoporosis, so low bone density mass. And of course, as I said before, there's poor memory. There is increased dementia risk in the long term with epilepsy. There's the psychological issues and the social problems, etc. So now going to epilepsy and disease, because obviously people with epilepsy, they may have other conditions as well. And epilepsy is often associated with obstructive sleep apnea, hypertension, or heart disease, like ischemic heart disease, for example, asthma, arthritis, osteoporosis, gastrointestinal problems, kidney problems, and cancer. In regards to neurological conditions, migraine is more commonly seen in people with epilepsy, Alzheimer's disease, multiple sclerosis, Parkinson's disease, and tremor. Psychiatric depression, anxiety is much more common in people with epilepsy. Also, there is an increased risk for schizophrenia or psychosis, harmful alcohol use or alcohol dependence, and illicit drug use. And within the neurodevelopmental sphere, more people have ADHD, autism spectrum disorders, intellectual disability, and cerebral palsy. And the different mechanisms, and I don't want to bore you too much, but the comorbidity may lead to, for example, to the epilepsy. For example, let's say you had a stroke, for example, and then you ended up having seizures, so you had a brain injury, you had seizures, or the epilepsy caused a comorbidity, so you had a seizure, you fell, you broke your bone, or you take some medication, you thin your bones, and then you have osteoporosis, which is basically the third one, the epilepsy treatment. You can have seizures and a comorbid condition, and usually in the context of developmental and epileptic encephalopathy. So usually people who have cognitive problems or behavioral issues, etc., etc. Or there is a common risk factor. For example, let's say you have hypertension, for example, and the hypertension gives you a stroke, but also is a risk factor for seizures, or it could be a neurodevelopmental condition. And again, there's another where there is an interaction, kind of, not interaction, but there is an association, bidirectional association between the epilepsy and the condition. For example, and I will talk about this later, if you have dementia or migraine, there's more likely to have the other condition as well. So what are the implications of all these associations, right? So first of all, if you, in general speaking, in medicine, if you detect a condition early, is better because you can prevent the worsening and you can treat appropriately. And obviously knowing if somebody with epilepsy has another condition, we need to know about it, because if you have, for example, liver disease, most of these anti-epileptic medications are metabolized in the liver, so the metabolism may change, and you need to take this into account. The same for kidney disease. So there are certain medications, like, for example, levetiracetam, that go through the kidneys. If you have dialysis, for example, if you undergo dialysis, then the dose needs to be changed. If you have migraine, it is important to know, because you can treat both conditions with one drug. For example, topiramate would be an example, of valproate. If somebody has comorbid depression, then you need to avoid certain medications and prefer others. For example, we know that levetiracetam and topiramate can maybe trigger kind of low mood or depression or even suicidality in people who are more prone to these conditions. Bipolar disorder, again, somebody can choose to use carbamazepine, lamotrigine, or valproate that are considered mood stabilizers. If you are overweight or obese, you need to avoid medication that can potentially lead to weight gain, like valproate, pregabalin, gabapentin, and gabapentin, and consider topiramate that tends to be associated with weight loss. So all the coexisting conditions are important in their own right, because first of all, they need to be treated, and secondly, they need to be taken into account when you treat the epilepsy itself. And again, the anti-seizure medications can promote another condition, like bring to surface depression, or, for example, Parkinsonism. A typical example would be valproate. Some people start to have tremor. Osteoporosis, for example, or what we call enzyme-inducing drugs like carbamazepine, phenytoin. They can increase your risk of having a thinning of the bones in the long term. Kidney stones, for example, topiramate, zonisamide can give you that. high cholesterol. For example, carbamazepine could be a drug that can drive cholesterol levels up. Of course, there are drug interactions. For example, I had a patient who was given methotrexate for rheumatoid arthritis, and they had a seizure recurrence because the methotrexate reduces valproate levels, and then you can have breakthrough seizures. So because even if you haven't changed the dose of your medication, because of this interaction, what is actually left in the system is reduced, and the seizures may recur. Again, certain conditions can affect seizure control. A typical example is obstructive sleep apnea, and depression and anxiety. If you have depression and anxiety, this increases the risk of developing side effects from the medication. So I would just like to focus on 2 or 3 examples with regards to these associations between epilepsy and other conditions. One of the most common associations that we see is mental health issues, especially depression and anxiety. Agoraphobia is there as well, because a lot of people who have fear of seizures, they wouldn't go out of the house because of fear that they will have something in public, nobody would be able to help them, and they wouldn't know what to do. And there is different explanations for this association. For example, the polypharmacy or use of specific drugs, as I mentioned before, can increase the risk of depression, the psychological burden, and the psychosocial burden as well. And obviously, there is sort of the neurobiological mechanism, because the cause of epilepsy, or what is the dysfunction in the brain that can cause epilepsy, may also make you more prone to develop anxiety or depression, for example, or even account for your memory problems. Epilepsy and depression, there is a very good evidence that there is a bidirectional association. So basically, if you have epilepsy, then you're more likely to develop depression. And if you have depression, you're more likely to develop epilepsy. And this is something important to have in mind. So why we care about depression, for example? I mean, obviously there's a huge impact on people's lives. If you have depression and epilepsy, then it has been observed that it's more difficult to treat the epilepsy. So more people with depression tend to be refractory to treatment. And also the depression itself is the biggest predictor of quality of life. So it's not only the seizures or the frequency of seizures and the severity of seizures that affect your quality of life, but it's also depression and other comorbidities. And depression, it could happen with any type of epilepsy. It typically happens more with people who have temporal lobe epilepsy or drug-resistant epilepsy, but it could happen to anyone. And the problem is that this is underreported, is not picked up, is under-recognized, is under-treated, because there is this concerns in a lot of doctors' minds that some of the antidepressants, for example, may lower a seizure threshold, so may make someone more prone to have a seizure. So a lot of people decide not to treat, or they don't even think about it, so they don't diagnose it. So, or a lot of times people complain of low mood or loss of motivation, loss of interest, poor sleep, and this is attributed to the epilepsy or the medication for the epilepsy. There is another big association between epilepsy and ADHD. Again, it's a bidirectional association, so ADHD will increase your risk of seizures and the other way around. And this has been shown in studies. I'm not sure if it projects very well here. So the incidence of epilepsy in people who have ADHD is nearly 4 times higher compared to the background population, and it's 2.5. And if you have epilepsy, then the incidence of ADHD is 2.5 times higher than the background population. Again, the people with epilepsy, up to 18% of them may have symptoms suggestive of ADHD. They may not have the full, they may not meet the full criteria for ADHD, but they may have some of the symptoms or most of the symptoms. But the problem is that this kind of symptoms, or the ADHD itself, in people with epilepsy, has been shown to decrease quality of life, be associated with higher rates of depression, anxiety, and impaired functioning. And also some medications, especially in kids or adolescents, like phenobarbital, topiramate, and valproate, may worsen the ADHD symptoms. On the other hand, if you treat the ADHD, people get better, and the seizures even may get better. For example, there's a study here that shows that methylphenidate, which is one of the stimulants, improves the quality of life of children and adolescents who have difficult to treat epilepsy and ADHD. One of my favorites, obstructive sleep apnea, is obstructive sleep apnea is very common, and it can affect many systems. For example, in the long term, it can, apart from the poor quality of sleep and insomnia and having unrefreshed sleep and daytime sleepiness, it affects your memory, it affects your immunity, so your immunity goes down, your blood pressure goes up. You may have increased number of red blood cells because there is not enough oxygen when you sleep, right? And you don't breathe properly. There's not enough oxygen, so the body senses that and says, "Okay, I don't have enough oxygen. What do I need to do to for example, to increase the oxygen levels, the delivery to the tissues?" First of all, it interrupts your sleep, so you wake up, maybe subconsciously, then you start breathing again. The red blood cells start to multiply, become more, to carry hopefully more oxygen to the tissue. So then you have the blood thickens in a way, and your blood pressure goes up. Then you're a candidate for stroke or heart attack. So in the long term, it's pretty bad actually, and can make you more prone to depression, and you feel tired, fatigued all the time because you don't get enough sleep. And also, it has a close association with epilepsy. For example, obviously, as you may imagine, I mean, sleep apnea is more frequent in adult people with epilepsy, and especially older males. And of course, it's more common in people who are overweight or obese, and especially increase the risk of drug-resistant epilepsy. And basically, if you have sleep apnea, you're a higher risk, 50% higher risk of developing epilepsy at some point. So, and this also goes for sleep disorder breathing, which is kind of sort of encompasses sleep apnea as well. Again, the pathophysiology would obviously there's a disturbance in the body in general and also in the brain, because the brain needs oxygen to work, and there has to be a balance. Obviously, if you are sleep deprived or if you have a hypoxic episode, there is not enough oxygen in your brain at night, then the neuronal excitability may go up, so you may be more prone to seizures. And again, if you have epilepsy, potentially for some people, thankfully not, it's also common, you have an increased risk of central apnea. And unfortunately, if you have sleep apnea and seizures and epilepsy, then you're at an increased risk of SUDEP. Now, if you treat the sleep apnea, then with CPAP is a usual treatment, really, then there's a higher chance that you're going to become seizure-free if you have epilepsy. The seizure frequency will go considerably down. You respond better to anti-seizure medications, and you have increased quality of life. So I hope that I have convinced you that people with epilepsy can have other chronic conditions, and indeed, a lot of people do. And this is what I personally say, and I'm sure all my colleagues see in practice. And if we take a step back and think, why is this important? First of all, if you have epilepsy and another chronic condition, then you have two chronic conditions, and then you become multimorbid, or you have multimorbidity, because that's the definition of it. And comorbidity is basically if you have another coexisting condition. For example, if you have epilepsy and ADHD, then ADHD is comorbid with epilepsy, or depression is comorbid with epilepsy, because they happen together more often than by chance. So there is some kind of association. And multimorbidity is a general term that says, if you have two conditions or more, then you have you're multimorbid. And to have multimorbidity in Australia, is of presence of chronic disease is pretty bad in Australia. You see here the percentage. It's over here with us is some sort of moderately high, not as high as I think some areas over east, but it's pretty bad. And so how is it relating to epilepsy though? Because chronic disease, a lot of people have it, but generally it's not good to have chronic disease because it affects your health and your quality of life, and you lose years of life if you have chronic diseases. And then we need to think, okay, what predisposes people, what are the risk factors for chronic disease, right? Because epilepsy is a chronic disease, and you can be associated with other chronic diseases, but what drives all this? Of course, it could be the epilepsy needs associations or the treatment, but there must be other factors, right? Because we don't live in isolation, in a bubble, we live in a broader world. So, for example, things like hypertension, smoking, excess alcohol, use of medication, and a lot of this stuff, not much exercise, all these sort of risk factors for developing chronic disease. For example, tobacco use is number one, being overweight, an unhealthy diet, high blood pressure, and excess alcohol use, right? These factors, if we manage that, we can prevent a lot of problems. And these factors can affect anyone, like people with epilepsy or without epilepsy, but they can affect also people with epilepsy. We need to know about all this stuff. So, what is the implication? So, people who are multimorbid, so they have more than epilepsy and another condition or more, then they're more likely to have to take a high number of drugs, so they have polypharmacy. They're more likely to attend the hospital or go to ED. They're more likely to have high rates of depression or suicidality. The mortality goes up, so they're more likely to die prematurely, and the quality of life goes down. And I found this interesting article that obviously, as you can read, individuals who develop drug-resistant epilepsy within a year after initial diagnosis have a higher burden of mental and physical diseases 1 year before the diagnosis. So the presence of chronic diseases in itself not only predisposes you to developing epilepsy, but drug-resistant epilepsy, so difficult to treat epilepsy. Now, I am in the process of publishing my own data. So this is data from 330 people that I've seen in my clinics over between 2019 and 2021. And I was surprised myself to see this. So nearly 80% of people with epilepsy that I see have at least one chronic condition. So nearly 80% are multimorbid. 60% have so epilepsy and two other conditions, so 3 conditions in total, and 40% have epilepsy and 3 other conditions. And if I break it down to medical conditions and psychiatric, then at least around 2/3 of people with epilepsy have another medical condition, and nearly 2 out of 5 have 2 other medical conditions. While psychiatric, thankfully, the numbers are a bit less. So people with epilepsy, nearly half have a psychiatric condition, and nearly a quarter of them have 2 or more psychiatric conditions. For example, it could be depression and anxiety, it could be depression or ADHD, or any combination you like, or it could be depression and alcohol use and stuff like that. And a third of people with epilepsy have a combination of at least one medical and at least one psychiatric condition, so have a mixture of conditions. And again, there are a lot of drivers and explanations for this. I mean, obviously a lot of environmental factors, so it depends where you live. Social factors, employment, use of alcohol, for example, smoking. Genetic factors, so you may be more predisposed genetically to have seizures and, for example, depression or schizophrenia. Behavioral factors, this refers actually to bad habits like smoking and alcohol and drug use, etc., etc. Polypharmacy, so the number of medications you take. And one factor that we, as doctors, we don't really pay too much attention, because I think we can, maybe the feeling is that we don't really can do a lot about it, but it's the social determinants of health. So what drives, apart from all the other factors, the medical things, what are the social factors that sort of affect your health? So, for example, the level of education, how much you understand about how much sort of you understand about health and your own condition. What is your job? For example, some jobs are more stressful than others. Do you have access to healthcare, or do you understand what doctors are telling you? Do you have support from family and friends? And if you need to, for example, if you, let's say, you have memory problems and you forget to take your medication, is there somebody in the family or in your environment to help you make sure that you take the right medication when you need to take it, when you fill in your scripts and take the right medication so you don't run out, for example. These are all important, right? And if we take a bit of a longer overview about health in general, which is basically what determines our health, which is basically what happens in the outside world where we live. Of course, we all are born with certain combination of genes that we cannot do nothing about, but this may predispose us to certain conditions. And then we all, let's say, there are sort of risk factors that affect pretty much all of us, but maybe different proportions. Like, for example, as I said, alcohol use, smoking, your diet, level of physical activity, you're a couch potato, you're a kind of a sports person, had infections. It has been shown, for example, that infections early in life, in childhood, can predispose you to having chronic diseases as an adult. For example, head injury, mental well-being, and of course, the level of education. So this will, based on your genetic background, will maybe increase your risk or decrease your risk of developing certain conditions. And this is where the primary prevention comes in, which is basically predominantly it should be through the GPs. And then if you go to the next stage, then you end up with, higher levels of diabetes, hypertension, cardiovascular disease, stroke, for example, that is relevant to epilepsy because having a stroke or hypertension can increase the risk of seizures. Any chronic inflammation, and then this needs to be managed, and this is where the secondary prevention comes. So what measures to reduce all this burden. And then you develop the neurological problem, which is basically the end of the line in a way, and then it's maybe too late to do too many things. So what I think is important is we all try to address things further back as early as possible to avoid things getting worse and worse over time. So these are things that sort of the social aspect of things and the medical aspect of things and the risk factors, these are things that we usually see. So I call them the outside world. But there is the hidden world, things that we don't see. And I'm going to talk about the gut bacteria. And so, for example, as I said before, there's things that the genetics, we don't know what we carry. We don't really know if we're in increased risk of developing blood pressure in the future, or a stroke, or cancer, or epilepsy, or ADHD. We don't know anything about that. Sometimes you can get clues about other family members who may have these conditions. There's the metabolism. We don't really know what our body does, our liver does, or the kidney do. and there's inflammation, which may happen without us knowing, and the effects of medication, for example, okay? And then you have the bacteria. All of us carry bacteria, trillions of them. We have it everywhere, in the skin, in the lungs, in the mouth, in the gut, everywhere. We're covered with bacteria. We don't see them, they're there. And one interesting aspect is the gut bacteria, which we tell macrobiota, because it's not only bacteria, but there are fungi and viruses and different creatures that live in our gut. And basically, they account for most of what comes out of stool. And they cover the line over the gut structure, and they form like a kind of a thin wall. And I said there are trillions of them, like over 100 trillion. And we all carry them. And what type of creatures we carry depends on the genetics and depends on how we were born. If you went through the vaginal canal, or you were born by C-section, and what your mother was carrying, and what we were eating when we were kids, and all this stuff. And but they are there because they support our body function, because they play a major role in the digestion, immune function. They have been linked with mental health and regulate inflammation. And we carry them all our lives, and they have been shown, particularly in animal experiments, that they can affect the level of satiety. So, for example, you eat and you feel full, or you want to eat more, and in a way they can sort of guide our behavior without us understanding or knowing about it. And of course, because they are so central to the absorption of food and nutrients and the regulation of immunity, they obviously affected by lifestyle and diet, and also affect what goes in our blood, what nutrients are released in our blood, or what substances are released in our blood. And I have to say here that the gut is not only about, it's not that tube that only absorbs medication and releases that, so what we don't need outside our body, but also is full of has billions of neuronal cells, and the theory goes that the number of nerve cells to regulate the movement of and the function of the gut is as many as the cells we have in our brain. And also the gut is lined with immune cells, because the gut is kind of in contact with the external world, so it has to protect us against the outside world. So there is a lot of immune cells in its wall, and this explains a lot of the function, a lot of the significance of the importance of the gut bacteria. And it has been associated with a lot of different things. Obviously, immunity, immune response. They provide, because they break down certain nutrients that we cannot. They don't have the enzymes to break. They provide 5 to 10% of our energy requirements every day. And they have a protective role against the pathogen overgrowth, so they're protective. And they play a role where they are with regards to the local good function of the gut, including a vascular supply and immunity. They regulate a lot of endocrinological functions and signaling to the brain, and also have helped maintain the bone health. We produce a lot of vitamins because of the gut bacteria, and also they have a role how to break down drugs and how the drugs are disposed of our system, and help eliminate the toxins. So, for example, the short-chain fatty acids that are produced by the bacteria, the source of energy, tryptophan that is produced by bacteria can regulate the immune responses. some other factors that may be produced, as this chemical called TMAO may promote atherosclerosis, heart failure, cardiovascular disease, and high blood pressure. If there is more production of secondary bile acids, this can promote cancer. The gut bacteria produce branched chain amino acids that are essential amino acids that we all need for health, and have an effect on glucose metabolism and lipid metabolism. So there is some association there with the risk of developing diabetes and heart disease. They can produce polyamines that are substances that suppress chronic inflammation, and they produce a lot of vitamins, like help produce vitamin K, all the vitamin B complex like thiamine, folate, B12, pyridoxine. So what happens when they go wrong? So usually there's supposed to be a balance in the gut. So these are commensal bacteria that sort of live there in harmony with the body. But if there is, let's say, if you use too many antibiotics, for example, or if they have some other condition, then this fine balance may go wrong, and then you may develop a higher number of what we call pathogenic bacteria, that's sort of harmful bacteria that create disrupt the local environment. So you lose your protective role, and you can promote inflammation. And they can affect the integrity of your gut. So you may develop a leaky gut. So you're more prone to everything that sort of passes through the gut, instead of being chucked out, is absorbed through the blood, all the toxins, for example, or bacteria. So you can promote inflammation. And it's also important here to know that it's not the gut is very much connected to the brain through the vagus nerve. 90% of the traffic on the vagus nerve comes from the gut. And of course, there is association with a hypothalamic pituitary axis, so all the endocrine changes that regulate stress, for example. I guess I told you about immunity, and I told you about metabolism and sort of the role in inflammation. So everything is interlinked and interconnected, but we don't see any of it. And with regards to epilepsy, there has been studies that shown that there is there is a link, between dysbiosis, sort of the harmful bacteria, and epilepsy. There's some studies that show that there is the excitability in the neurons goes up, so you may be more prone to have seizures, for example. And there are differences with regards to the gut bacteria in the gut of someone with epilepsy compared to someone who doesn't have epilepsy. Now, is this a cause and effect? We don't really know what drives what. It could be maybe a combination. But we also know that certain treatments, like ketogenic diet, for example, also causes changes in the gut bacteria. So is it the diet itself, or is it the gut bacteria change, or is it both? It is not known. But animal models, because a lot of these experiments were done in mice and rats, they have demonstrated there is for sure there is an association. So to summarize, and I hope I haven't bored you, epilepsy is a chronic disease. Is associated with impaired quality of life, comorbidity, and multimorbidity. This creates problems or difficulties for management of the condition, because there's a lot of other factors that somebody needs to take into account. So a lot of these issues that we need to take into account, we understand, but and we all try to achieve a best disease outcome, whatever. For example, in epilepsy, reduce the seizures, stop them completely, and so people can be seizure-free and go on with their lives. But also, our decisions are affected by things that we don't always see, we don't always understand. So my message today is that epilepsy is much more than its name. in my strong personal view, comorbid conditions need to be diagnosed and treated, and sometimes it's more important than the epilepsy itself. Common health risk factors affect everyone, and can and should be prevented. A healthy lifestyle is good for epilepsy, so we'll all need to look after our diets, make sure we get enough sleep, exercise, avoid toxic factors like excess alcohol, tobacco, drugs, illicit drugs, and have a good and meaningful social life and try to have support in our lives. And me being Greek, as the Greeks used to say 2,500 years ago, nous υγιείς and soma υγιή, which means anima sana and corpore sano. So in Latin, a sound mind and a sound body. We need to look after our bodies. Thank you very much.